for that introduction, the kind introduction. It's a pleasure to be here back in Bangladesh. So thank you to the organizers of the conference for putting this together. This is a topic that's very near and dear to me, and I'm involved on the coronary side and on the peripheral side, and so today my topic for this session is below-knee interventions, current challenges and prospects. Oh, it's not showing on the screen. Okay, there it is. All right, here are my disclosures. So we'll talk about peripheral arterial disease. We know from lower extremity registries that we've had that PAD, peripheral arterial disease, can be very diverse. They look very different once you're aortic disease versus infrainguinal disease versus below-the-knee disease. And so there's a variety of reasons why we intervene on these patients, ranging from claudication to rest pain to tissue loss. And overall, the effects or the outcomes of these procedures can vary significantly based on what you're dealing with, whether it's related to just primary de novo stenosis, or if it is a chronic total occlusion, or if there's prior stents in there and it's a restenotic lesion. All of these can affect the outcomes of these procedures. Moreover, once we get below the knee, which is what we're going to talk about today, it adds a variety of other challenges. Once you get below the knee, there's less flexion, there's contraction and torsion, especially around the knee area, and then there's compressive forces from the calf muscles on these arteries. And these vessels are pretty small. They range from 1.5 millimeters down in the feet to about 4 millimeters in the proximal tibial vessels. And there's a lot of low flow and high flow, high resistance segments. And there's a variety of different collaterals that come into play as well. So how are these lesions different from above the knee to below the knee? Well, once you get below the knee, typically based on studies, there tend to be more calcific lesions. So you'll see that 75% of these lesions are calcified. It's dense calcium most of the time in the tibial vessels compared to popliteal and femoral. The vessels, as I said, are very small, and they can be extremely tortuous as well. So the traditional surgical approach has been to open inline flow to the foot. And so that's the idea of creating a bypass to get inline flow down to the foot. And once you get inline flow, then you could potentially resolve the symptoms or heal the ulcer. But today, our BTK interventions, below-knee interventions, have changed, have evolved significantly. And now we use primarily the angiosome concept. And what is an angiosome concept? Well, angiosome is an anatomic unit of tissue, so fed by a source artery. So depending on what artery feeds that area of the foot, you're able to revascularize specifically the artery that is affecting the ulceration or breakdown of the skin. So using that criteria, there's 6 angiosomes that feed the foot, and that's the picture on the right that shows you the different color scales of what an angiosome is and what artery feeds that area. So if you know that, then you can specifically treat the artery that feeds that area of the foot. So the concept is that the artery that directly supplies the ischemic angiosome should be preferentially revascularized in below-the-knee interventions. And the goal is to maximize any ischemic ulceration healing and improve any surgical incision or amputation that's been done. So for example, if you're doing angiosome-guided intervention, if you have a lesion in the dorsal foot, then you would treat the anterior tibial artery. If it's the plantar foot, you would treat the posterior tibial artery. If it's the lateral foot, you would treat the peroneal artery. If it's the calcaneus or the heel area, it's probably the posterior tibial artery or the peroneal artery. And so this gives you an idea of how to proceed or how algorithmically as to which artery to fix. So the question is, does this actually matter? Well, there's been some studies that have been done that have been primarily retrospective, looking at 52 non-healing ischemic ulcerations. There were two different study groups. There's direct revascularization by bypass to the artery directly feeding the ischemic angiosome versus indirect revascularization, bypass unrelated to the ischemic angiosome. So you just do a bypass to whichever artery that's patent. And there was no statistically significant differences between the groups in comorbidities. So the endpoints were looking at complete healing, amputation, and death. And so in this population, the bypass target, 42% of the time was the anterior tibial artery, 33% posterior tibial, and 25% perineal. The postoperative mortality rate was 17%, and we looked at the analysis here. So what's really interesting is when you looked at direct revascularization, where it was directly revascularizing the artery that affects that area of the foot, there was complete healing 91% of the time. So failed to heal only 9% of the time. Whereas if you did indirect revascularization and just revascularized something else, some other artery, you only had 62% complete healing. So the conclusions are that the artery that directly supplies that ischemic angiosome should probably be the one that's preferentially revascularized. So to do, complex below-knee interventions, you need to have a variety of tools. And one is access, being able to access at multiple points, being able to do antegrade, which is the front door access, doing retrograde coming from the foot, which is back door, and then what we say transcollateral, which is side door. You should be able to do transpedal access coming from the foot and going backwards to be able to revascularize. You should be able to familiarize yourself with different techniques like cart and reverse cart and parallel balloon and facilitated reentry. These are different techniques that you can use to cross these complex calcified lesions below the knee. There's so many different devices that are available to cross CTOs that are presumably intraluminal to cross, and many different reentry devices that can be used as well to reenter the true lumen. And then there's a variety of atherectomy tools as well to do different kinds of atherectomy once you get to these occlusions. So in conclusion, we're running out of time, but below-knee interventions involve technically challenging anatomies. So understanding the angiosome concept, I think, is most important, and directing the flow to the target vessel that supplies the ischemic territory. Have expertise with various access options, be knowledgeable of various technical strategies for revascularization, have a variety of tools available to cross and revascularize, and then if you're able to do all of that, you can have excellent wound healing outcomes with revascularization. And with that, I thank you for your attention, and I'm happy to answer any questions.